Hi, I'm Lisa. I am with the SHARE project. As you might know by now, SHARE stands for Spreading Hope and Awareness and Removing the Epidemic Stigma. But one thing you might not know that we haven't really talked about yet in these videos is how and the reason that SHARE got started. Michelle Rogers and I decided to start this project because we both had in common sons that suffered and struggled with substance use disorder, and then ultimately we both lost those sons to an overdose. And one of the things that we realized throughout the process that is the value of talking with someone else about what we were going through. And unfortunately, we didn't learn this until a little later in the process. And so one of the things today, and one of the things that we want to get across in this interview today is spreading hope and helping others to realize that there is someone to talk to, that you are not alone in either your grief or alone in learning tools to navigate parenting someone struggling with substance abuse, and learning boundaries, those types of things. So today, that's what we're doing. We're spreading hope today. I'm talking with Robin Minnick. She is a counselor with RR Minnick Counseling. I'm going to let her tell us more about herself, and we're just going to take apart what counseling and therapy means. Is there a difference? Those types of things. So I'm going to let her introduce herself. Tell us a little bit about your background, what your training is, those types of things.
Okay. You asked me originally where I was from. So I'll just say very briefly that I was born in Little Rock, Arkansas. I was raised in southern Illinois on the banks of the Mississippi River. I lived in Indiana, so I'm a Midwesterner at heart, but for the last 36 years I've lived in North Carolina, so I say I'm from Waynesville, yes, North Carolina. I have 5 adult children and a handful and a little more of grandchildren, most of whom live near me, so that's a wonderful thing right now. My husband is a musician and also has his own business. Most of my work until I was 50 years old was in the nonprofit world, working with families and women and children. So I did a whole range. I started with Reach of Haywood County and worked with as an advocate for court advocate for sexual assault survivors. I worked doing mentoring programs for youth who were at risk. I did adolescent pregnancy prevention. I did project management for the Region A Partnership for Children, which is a nonprofit that administers early childhood programs across the 7 western counties. So that's what I did before I went back to grad school. Okay. And that was in 2006. And I got a master's degree, which is what you have to have in order to be licensed as a clinician. I originally went to the master's in counseling because I was sort of from a spiritual approach, really. I had engaged in a ministry inquiry process through the church I was attending, and I had a mentor and was just sort of trying to discern what I wanted to do with myself, how to bring my spiritual life and my vocational life kind of on the same page. Yes. So after I went through that months-long process, I went back through the workbook and I kept seeing the word counseling skills. I'm like, okay, I'll just get the skill set. I won't be a counselor, but yes, I'll just get the skill set. Yes. That seems to be. So I found a wonderful program in my own backyard at Western Carolina University, and I worked full-time and still had teens at home as I worked my way through that program. It took me 6 years to do it, and that's been almost 10 years ago now. So I worked, started with Appalachian Community Services as a community-based mental health agency. I went from there to working at hospice, where I worked as a grief counselor and program manager for 4 years, and then I went into private practice, which I've been doing for the last 4+ years.
So wide range of background as far as people that you've helped and the experience that you would have gotten from just encountering all these?
Yeah, and I think I really do feel like everything kind of led up to what I'm doing now and contributed to it. Yes, I agree.
Absolutely. So do you, first off, let me ask this, is a therapist and a counselor the same thing?
There are lots of words for us.
Okay.
Yes, you could be a psychotherapist, you could be a therapist, you could be a counselor, you could be a clinician. A lot of us use that word because it really shows that we're, that there's some understanding behind what we're doing. We're doing clinical practice. So right now I'm a licensed clinical mental health counselor.
Okay.
So my work is based on research and on what works and doesn't work.
Okay.
Yeah.
So in your practice then, do you, since you do have such a wide range, do you have a specialty, or do you, I mean, are you just a grief counselor? Are you just a, or do you have a wide range that you?
Well, I have I've added a couple certifications to my credentials. I do have a certification in grief counseling. I have a certification in clinical military counseling because I have a heart for the military population. I have some of my children were in the military, and even my family, you know, my parents. So military grief. I also was recruited to be trained and certified in perinatal mental health disorders, which just means the period a year before birth and then the year after birth. So there's a lot of stuff that comes up around that. So I'm certified in that, and I have just mailed in my certification for a very beautiful therapy model that I work in, that I've trained in extensively, and hope I've got all the work done for that. I'm just waiting to get that approved. So, yeah.
Do you have one you enjoy more than another? Or no?
No, it's all good. It's nice to have some specialties, and you know, there are some of the things. Almost everyone has experienced some kind of trauma. Lots of folks have a history of anxiety or depression. Some of these things are generational. They come through us, you know, to us through our families. And so, no, what I really like, so people ask me, what's your favorite kind of patient or, you know, client? And I say, the one who works.
Yeah.
The one who engages, because I don't have a magic wand. I don't fix people. But I engage with people to help them reach the goals that they want. Yes. So the peace they want.
Yeah. Okay. So do you find that most people come to you because of, you know, some history with mental health issues, mental illness, or would most of them just come to you because they're having a hard time navigating certain life issues, you know, like grief, or like parenting a child with substance use disorder, those types of things?
I think they go hand in hand.
Okay.
So here's why. So pathologizing means giving a diagnosis. So we give a diagnosis for two reasons. The same reason that a doctor would give a diagnosis. So we know what we're treating, and so we can receive payment for our services.
Yes.
It's kind of odd like that. But so we diagnose so that we know what we're treating. So, but you know, most of us, anxiety at some very fundamental level is a healthy thing. In excess, of course, it's not healthy, and we have to learn to manage it. Depression is something that a lot of people struggle with. Clinical depression is different than just having ups and downs and a low day, or you know, now and again. So I would say it's a mix. Adjustment disorders are most commonly diagnosed. That just means that latter thing that you mentioned, just sort of trouble getting through a period. And lots of people, for example, right now are really struggling with some changes related to COVID-19, and that's definitely made, just like it has for most of us, you know, whatever was going on already, it sort of fanned the flames and blew it up into a bigger conflagration. So, so yes, some people have a history of mental health issues. Some people have never been diagnosed. and are just coming to work through things that they're dealing with. Yeah.
Do you think that we could all benefit from a little therapy at some point in our lives?
Probably. It's hard for us to see our own blind spots, right? We can't really judge the things, and sometimes a lot of what therapy is just holding up a mirror. So I say to people a lot, you don't come to hear what I have to say, you come to hear what you have to say. So it's just helping people slow down enough. A lot of times they get unhelpful feedback from others, or they're just told to just suck it up and keep going, or so I think we all need to be listened to, we all need to be validated, and sometimes it's helpful to have someone outside of our story to do that for us.
So as it relates to grief from losing a child, specifically to substance use disorder, do you feel as though your counsel to the parents is more along the lines of helping them just learn how to deal with the grief, helping them learn how to not feel blame, to take on blame? Do you find that a lot of times there is blame that they feel? Are you able to help them get past that? Or is it something that's always going to be there and you just have to learn to teach them how to deal with it?
So it's yes and yes,
yes
and yes. The model for grief now, so the current research around grief is a meaning-making model. So it's about making sense, making meaning out of the death, making sense of it. And so the grief work is around tasks that help us make sense of what happened. As a parent, I think we are always going to, look in and say, how did I contribute to this? What was it my fault? And yes, we do. One of the biggest things that we're trying to make sense of is our helplessness. We often, and not just when it comes to addiction issues, but with other issues, we slide into what's called codependency, where as a parent, we get our needs met by trying to help our kids do the stuff that they really need to be doing on their own.
Yes.
So, and it's especially, we're especially vulnerable when it comes to addiction, I think, of that, because we feel so helpless. And helplessness is one of the very worst feelings that people experience. We have very little control over most things. It's very hard for us to acknowledge that, but the thing we have the most control over is our own thinking. We don't exercise that nearly to our capacity, but that's where we do have control, so that is where we work. My favorite word is notice, and my least favorite word is should. Okay. So a lot of times, no, not I should have, I should, or I should have, but it's I could, or I could have. Here are the 6 reasons that I didn't, or here are the 10 things that I did do. As we're trying to make meaning out of what's happened. So notice is what I do a lot of in counseling for my clients, my patients, and I encourage them to notice. Just notice. Sometimes stuff keeps coming to us in our grief work. It keeps knocking on our little door. Sometimes we just need to be sad. We need to notice the sad part and kind of bring it over and sit it on our knee and go like, I know, we're sad. This model that I work in uses this language, a part of me, instead of I am. It's a huge distinction. So a part of me is very, very sad. A part of me is hopeless. A part of me is afraid. Not I am hopeless, I am afraid, I am sad. So if it's just a part, we sort of unblend it from our I am, and then we can deal with it. And sometimes we have to lean in to the sadness. What we know is buried feelings don't die.
Yes.
We can bury them, but that does not mean they're dead. They're going to keep coming until we lean in, until we pay attention. And I think the kind of counseling that I do is a way for people to sit with their parts, to meet those parts of themselves that they've been trying very hard to stay away from. Befriend them, learn from them, see how those parts are actually trying to help them, see what those parts are afraid of if they weren't working so hard. A lot of people, like, how could it be that you would be afraid that you would forget your child? You know, but a lot of people are, I think, there's a part of them that's afraid if they quit being sad, or if they quit, you know, crying all the time, it'll mean they didn't love them, or they're forgetting them. And so we hear those parts out, and we tell them, oh, no, that's not going to happen. And here's why, and I can take care of that. You don't have to anymore. So that's a little bit of the way we work.
So tell me then a little bit, you're kind of even referencing it just a little bit here, describing that. Tell me, what does it look like when somebody goes to a counselor or a therapist? You know, we all have this, I'm sure, a misconception. it to some extent, you know, what you see on TV, you go into the office and you recline on the couch and you're just, you know, talking and, you know, sharing your woes of the day and those kinds of things. So tell me some of the ways that you talk to a client, talk to somebody you're working with. What are some of the different types of treatment that you have and offer? And do you use the word treatment? Is that a proper term?
I think it is a term that's appropriate. We're treating symptoms, right?
Okay.
Just like, right, we apply a remedy. So treatment is like the remedy. I often encourage people, so I can only speak for myself. Counselors are all different.
Yes.
Every one of us is very, very different. So all I know is what I do and what works for me. I will say that research says that the most important thing for the success of the client or the patient, I call them patient instead of client. Client is like a business relationship. Patient is someone that you're taking care of, that you're treating. So I just, not very many people in my field use that term, but that's what I use because I feel the most comfortable with it. So, I just distracted myself. Let me think.
We're talking about treatment options.
Treatment options. People have reasons they're coming, so I get them to define, what do you want to be different because you're coming and spending your time with me? Well, I want to feel less anxious. I want to be more hopeful. I want to not be so sad. So we're goal-oriented, which is treatment-oriented. Treatment is supposed to be goal-oriented. What are we working towards? We can't just get here and just chatter away.
Yeah, there is an end game.
Right.
Yes.
So the first thing I do is really listen. That's the biggest thing. What do you want to be different because you're coming and spending time with me? There are lots of different ways to do the work and to access the parts, as it were. The model that I love that I told you about, and has to do with these parts, is called internal family systems. So it's how our parts relate to each other on the inside. So it's the part of me that wants to do this, but the part of me that's afraid. So it's not multiple personality disorder or anything like that. It's just all our different sort of parts. I love working in that model. It's the most efficient way I know to do therapy. We can talk for years and not get where we get in one session using that model, which is client-led, patient-led. The patient's own system leads the way, and I'm sort of the guide. So that is a little, it's now an evidence-based model, which I'm really happy about. It's not your usual way of doing treatment. It's highly effective. So mind, body, heart, one unit.
Right.
So one of the things I do a lot is help people with what's called somatic awareness, so awareness of their body. So a lot of people stay in their head all the time. They think.
That would be me.
And and the body has so much information for us that so I'm always trying to get people out of their head and into their body. What's your body telling you? What do you notice in your body? So there's a beautiful guided meditation it's based on a yoga sutra. where you think of a negative feeling, a negative thought that you usually hold about yourself. You find where that sits in your body. And then you focus your attention on that negative feeling in your body associated with that negative thought. And you see how you tolerate that. Then you drop that and create a flip side, a positive thought. Find that in your body. See how that feels in your body. And then sit with that. So that's, so somatic awareness, using your body at any given point, doing a little scan. Oh, I've got a little tension, me a lot in my neck and shoulders. Oh, what's that telling me right now? Oh, it's telling me I'm worried about the election results.
Yes.
Or something like that. It's November the 4th. Or, you know, or I'm worrying about this, or I haven't let go of that yet. So I use body awareness a lot, and a lot of people are very disconnected from their body. They don't even know what I'm talking about when I'm like, where do you find that part around your body? So that's big. There's a really neat aromatherapy clinical model that I'm working with. It's called the Aroma Freedom Technique, and it's using essential oils in kind of memory, releasing negative memories. And so there's a lot of research, again, behind the olfactory nerve and the brain. So the brain talking, and smell is a trigger, we know, and so we can train our brain to recognize smells and then like induce calmness or something like that. Image, the use of image. There's tons of work doing neuroscience work, research on the brain right now that's just has great implications for all of us. So part of it is the use of an image to calm. The image, finding, so what's a calming image for you? For a lot of us, it's the ocean, the mountains, a river, a tree, our back porch, whatever. And we hold that image as a way to show our brain that we're trying to calm our system. So the brain, when we see the image, the brain goes, oh, we're connecting that with calmness, and our system calms down. So those kinds of things I use in my practice a lot. There's a great technique for treating trauma. There's tapping, which I don't know if you've heard.
I'm familiar. Yes,
Okay, so tapping is about releasing negative emotions. There's a great tool for, it's called alternate heel tapping, where you just lift one heel up and down while holding a negative image or a trauma memory, and it moves it from the front of the brain to the back of the brain. It just works. All you got to do, is that. And I have patients with severe childhood trauma who have used that. Doesn't get rid of it, but it moves it to the back of your brain so it's not firing off all the time. So that'd be a great thing for some of the folks who have experienced the death of a child. So those kinds of things. Guided meditations I use a lot. Those are wonderful to help calm the system.
Okay.
Stuff like that.
Wow, okay. So see, all sorts of things beyond just going and sitting on the couch.
Yeah.
Yes.
Sometimes we do yoga. I've trained in some subtle yoga interventions. When I had my office, we would do just some brief yoga things. Getting right brain, left brain going, stuff like that. So,
would you say that there is a stigma, any kind of stigma around seeking help?
I'm sorry to say I think that is true. There's a culture of privacy, especially around here, but I think in lots of places. We don't air our dirty laundry. We don't, if you have a problem, you don't go talk about it. We're going to keep everything looking good on the outside. So privacy is a big deal. And I respect that. Thank goodness, confidentiality is a part of my ethical obligation. And so people can trust in that. My license depends on it, and I want to keep working. So, and plus, there's no reason to not honor what people share. But there's stigma. A lot of times, I think there's a lot of shame associated with mental illness, or even family histories of it that was just kept quiet. You just sort of suck it up. You should just suck it up. You don't just get over it. That kind of stuff. So I think there's a lot of messages we get either through family or culture that make it out as if we are weak if we're going for support.
Yes. Do you think any of that is somewhat, or do you see there's a line in generations? Do you think that a lot of those types of things that you're talking about, the shame, suck it up, do you see that as being in people that are a little bit older, and the younger generation is a little more accepting of therapy and counseling, or is that just pretty much across the board, would you say? Just curious about
I'm not
that.
sure what I could say. I know that I hear, and I know from my own upbringing, that there is a lot of generational, there's a lot of protection of image. You know, we can't be weak, we can't be vulnerable, we can't let other people know we're having a hard time. I know there's a lot of legacy stuff that we all deal with that's come through our great, to our great, to our grandparents, to our parents, to us. It comes through, and I do a lot of work actually with people around some of those, what we call legacy burdens, things that like just came down to us without, you know, sort of landed on us through the genetic line, and substance abuse is one of those things actually. Can be. I don't know so much about the younger generation. I think there is a lot of shame. It takes, you know, you're going and talking to someone, you're being vulnerable, and we as a people are not. We don't know how to be safely vulnerable. Our trust has been violated before. So by gum, we're not going to put that out with somebody. They might make us feel bad. Or people have had negative counseling experiences before. And so they're like, I'm not doing that again. You know, they made me feel horrible. And so I think there are many, many reasons that make it difficult. We're going to someone we don't even know and sharing our most vulnerable stuff. So and that's just hard. It takes a lot of courage to come to counseling, but the goal is really owning your, you know, what do you want for yourself? What do you want to be different? And believing that you can use this as a way to make some change.
Do you find that most people stick with it and stick with counseling and, you know, continue on through to the end, or do you find that oftentimes they get to a point and they just don't want to continue anymore?
It goes both ways. It has to be a good fit. It has to be a good fit. You know, so it's like and I encourage people to search. There's platforms. There's a platform called Psychology Today where you go and read profiles and see pictures and see people's approaches. I went on there and read a bunch of my peers. I'm like, I have a very different approach than, you know, which I didn't really know until I went. So you should shop.
And if I'm not mistaken, I think you can correct me if I'm wrong, but even within that platform, that Psychology Today, you can, or .com, psychology.com, is that what it is?
It's psychologytoday.com.
Okay. You can put in, you can narrow down your search.
Right.
You know, if you only want a female, or of course, what's your issue,
or your or your insurance type.
Your self-pay and, you know, location, of course. All those. Narrow it right on down.
Male, female, yes. So, but that's a wonderful way because, you know, it has to be a good fit. If it's you find out fairly quickly if it's not a good fit, and it's nobody's fault. It's just, oh, I need someone younger, or I need someone who has direct experience with this, and you don't, or you know.
Okay. Well, you have given us all sorts of ideas, if you will. Can you give us like right now? If somebody is struggling with anxiety or stress, that would be very timely today. With COVID, with the election results, that we're waiting on those. Can you grief, if someone is, you know, in the beginning of a grief, can you give us something tangible right now, without infringing on your your paid work, that we could, you know, kind of implement right now if we were just one little practical thing?
The most practical thing. And it may be a secret, but it really, our best friend, always with us, is our own breath. So there is some science of stress and science of relaxation, and it's based on the breath. So our system perceives a threat. All the blood leaves our organs. It goes to our hands and our feet so we can run, fight, or freeze. And we get chemical dumps of sort of hormones and chemicals that are designed to put us on heightened alert. And what they say about most of us as Americans is that we stay in stress mode and we don't get out of it. So we're constantly breathing fast, feeling threatened, being hypervigilant, whatever, anxious, worrying, perceiving danger. The way out of that is the opposite of stress is relaxation. So we train our brain with relaxation, and the best possible and simplest and most accessible way to do that is through our breath. So belly breathing, so deep into below your tummy button, in through the nose. If you can want to do a couple cleansing breaths, you just out through the mouth. I feel almost instantly calm now. The more you do it, the more you train see, we're creatures of habit. Even our body, our breath is a creature of habit. So the more we train ourselves, 6 to 12 of those deep belly breaths, slow and deep, lengthening exhale and inhale and exhale, actually the brain goes, oh, they're not stressed right now because they wouldn't be breathing like this if they were. So we can kind of trick our own brain, and then out come the other feel-good chemicals, and we reset from the sympathetic to the parasympathetic nervous system, and we're in a state of calmness again. So the breath is the best possible way. For the other thing it does, it brings us right here, right now.
Yes.
When we're anxious, we're worrying about the past or the future, and then we're not here.
Yes.
So the breath brings us to the moment. Staying in the moment is one of the best ways to deal with anything.
Yep.
And so I would say research belly breathing. Let me know. I have a great handout on it. Using the breath. Whenever we're distressed or we're feeling out of self or discombobulated or worried or anxious, we can just do. And I feel it almost instantly now. I do a lot of it. I listen to a guided meditation every morning, just a little 10-minute thing that just helps me focus on my breath and settle my system down. Maybe has a little affirmation in it. But the breath is always with us. It's always our way to regroup, redo, and just take care of ourselves. So that's the best. That's the best thing.
That's a great tip. Yes.
But I wanted to say, then the other thing I want to say about that, the other thing we can do is name, notice, let go. So when something comes up, when some anxiety comes up, when we're terribly sad, just push it away and distract ourselves away. Sometimes that's an okay thing to do, absolutely. Actually, distraction can be a very useful tool. But what I'm talking about now is just naming it. Oh, a part of me feels really sad right now. I see you, I hear you, I know it. Let me just be with you for a minute. Let me just sit with you for a minute. Okay, now I'm going to let you go. So name, notice, let go is another thing that we can do to just honor. We don't get rid of any parts. Like we honor them, we notice them. They keep knocking because they want our attention. So we lean in. We give a little attention, and then we release. But can I go back to something?
Please, yes. I was going to ask if you wanted to.
Well, you in the kind of the questions that you gave me when you were talking specifically about the child-adult relationship when the child is engaged in substance abuse. You talked about setting boundaries and coping skills and such as that. And one of the biggest things I want to say, and one of the most difficult things, I think, for us all, and as a parent, this is very hard for me, to allow my children their experiences. We've done the best we can. It's all up. We're done parenting whenever we let go of it. And we have to allow our children. We can't fix them. We can't do anything for them. And it's very hard sometimes to, and this is true for our friends and our other family members. It may be a spouse, it may be a best friend, it may be ourselves. We have to allow each other our experiences. It's none of our business in some sense to try to control someone else or to make them be a certain way, to make them quit using, to help them do it. It's an individual choice. All we can do is take care of ourselves. That's hard. And allow other people their experiences. So helplessness is a very difficult emotion. We talked about that earlier. So we deal with that in ourselves. There's a part of me.
And you can help in your field. You can help a mom or a dad to learn some of those skills in boundary setting, or allowing your child or adult child to fail, or to learn to setting those boundaries and not always.
And a lot of it is sort of the Al-Anon. I remember I went to Al-Anon for a while to help myself, and it's like letting go of that which I don't have control over, and just realizing that is not mine. So what's mine? It's about responsibility. What is my responsibility and what is not? So if I'm taking care of someone else's responsibility, I'm enabling. What need of mine is getting met by that? So we talk about that a lot. Are you trying to make up for something? Are you trying to, you have some guilt about something that you're now trying to erase through this enabling behavior.
Yes,
so
yeah.
We look always in. This is true about counseling. It is always an inside job. It is never out there. It's always in here. So, yeah. So I really wanted to say that allowing choice and responsibility, accepting our own lack of control and power over our adult children, believing in a bigger picture, seeing our lives and theirs in a larger context that we may not even quite get, but realizing it's bigger than just what it seems right now. Those are the kinds of things I think. Definitely setting boundaries, saying yes and saying no. Goes both ways. We have to learn how to say no, and we have to learn how to say yes, and we have to learn how to know when to do those things. That's all learnable.
Yeah, it's all learnable. Yes.
Yeah.
Well, boundaries isn't about. It's about taking care of ourselves. It's not.
Right.
It's about self-care boundaries.
Yes.
It's about protecting ourselves, not.
Yes, and that's the other thing that I wanted to say. What can we do for ourselves? We can speak self-talk. We can speak kindly and gently to ourselves. We can not be harsh. We can tell ourselves we can accept ourselves just how and as we are in each moment. That's huge. We're doing the best we can with what we know and what we have. I truly believe that about all of us. But how we talk to ourselves about ourselves is really important. And there's no reason to not be kind. It goes a long way. Yeah.
All right. Anything else then?
Let me just take a quick look. But I think so. No, that positive self-regard was something I just really wanted to mention. I would say the 3 words I hear the most in my office are not good enough. And so I am always working with folks on finding ways to believe that we are right where and how we should be. Yes, we can always grow. Yes, we can have intentions, and we can set them and reach them. But there's a lot of power. So there's a lot more to talk about in terms of how it is we move from the place where we're out of sorts with ourselves to really feeling more at peace and happier with ourselves. There's lots that we haven't talked about today. But I would say that's a lot about what the counseling experience is like. It's sort of befriending yourself and working. This is why I say my favorite patient, the one who works.
Yeah, willing.
Because things happen, they can say, 2 months ago I would have never responded like that. Or I noticed that I did this, and in the past I would have done, So we look for progress. We're always celebrating baby steps of growth and change that let us know that we do have the ability to become more the kinds of people that we want to be. And I'm on that same path myself, so,
Yes, always.
yeah. So,
Okay, awesome. Well, I have been asking one final question
okay.
of everybody that I've been interviewing. And I think we can still, it's not quite as applicable to counseling as it is to some of the other resources that I've interviewed, but I still think we can turn it around.
Okay.
What is one thing that we here at Haywood County, here in this area, could do better? What would be maybe one final message that you would like to, to get across as far as it helping others either emotionally, mentally, what the stigma that is surrounding, what is one thing that we could do better so people do seek out counseling and help if they need it, and we are not a stumbling block societally or
It's very applicable, and here's what I would say. I would say, listen, don't try to fix it. Do not try to fix it. Just hear it. Because what people need, what we all need more than anything, is to be heard and accepted and to be validated. So hear, accept, validate. Don't try to go in there and make it better. Just, you're sad. This hurts. You feel helpless. You feel like you're to blame. Just listen and validate. And not try to fix. That's, I would say more than anything, we just need to be heard. And if we could just hear each other, this applies across the board. We always have a comeback, right? We're always cooking up our answer before the question's even out or before the person's done talking. We're like, oh, I'm going to say it. So what if we just really listened, understood how what someone was saying applies to their life? We call that advanced empathy. So if they're saying this, what would that mean for them? And then sort of helping them name that, reflect back what you hear. That's the biggest thing. And that is that is often all people need. Yeah, that's what they need, is just to be heard. So I would say that.
Okay, excellent.
Yeah, thanks for this opportunity.
Thank you, Robin. I appreciate your time today.
My pleasure.